Welcome to part 3 on this introduction to lung ultrasound. In this section, we'll be focusing on an approach to the diagnosis of acute respiratory failure using lung ultrasound profiles. The concept of lung ultrasound profiles was initially developed by Lichtenstein et al. In 2008 in his seminal study in which he assessed the accuracy of diagnosing various causes of acute respiratory failure using lung ultrasound, and ultimately found that blinded to all other clinical data, two evaluators were able to diagnose various causes with 90.5% accuracy, and this was using the Blue protocol. So in order to develop or identify a lung ultrasound profile, the first aspect to identify is whether or not there's lung sliding. And following this, the interstitial pattern, whether it's an A, B, or C pattern, needs to be identified. And so looking at this graph, when there's lung sliding, and if there are B lines bilaterally, we call that a B profile, and this is consistent with pulmonary edema. However, if, again, there's lung sliding, but instead of B lines, we see A lines, the next question that we need to ask ourselves is whether or not there is any thrombosed veins, in which we would need to do a venous analysis, and this is beyond the scope of this section. However, if we did identify a thrombosed vein, this would be consistent with pulmonary embolism. However, if there is no thrombosis identified, we would then move down into identifying whether or not there's any effusion or consolidation in the PLAPS region particularly, and if there was either consolidation or effusion, that would be consistent with pneumonia. However, if there is no consolidation or effusion, this pattern would be called a profile with no PLAPS, and this would be most consistent with COPD or asthma. Moving into the other side of the diagram, if lung sliding is absent and there's A lines present, we call that an A prime profile. This would be most concerning for a possible pneumothorax, in which case we would have to identify something called lung point, which we'll review in another slide. If that's present, then we are able to diagnose a pneumothorax. However, if we have an A prime profile without lung point, this requires other diagnostic modalities to identify the cause of respiratory failure. If instead of A lines we see B lines with the absence of lung sliding, we call it a B prime profile, and this is most consistent with pneumonia. Finally, moving into the last box, if we see either a combination of both A and B lines or a C profile, whether or not there's any lung sliding, we diagnose it as a pneumonia. The sensitivity and specificities of these lung ultrasound profiles for their associated diagnoses is quite strong, as can be seen in the table listed in the slide here. Just to review some of the data that was identified by Lichtenstein et al., cardiogenic pulmonary edema and an associated B profile, the sensitivity was 97% and specificity 95%. For COPD/asthma, the presence of a normal profile or A profile without any lung point or without any deep vein thrombosis, the sensitivity was 89% and specificity 97%. When there was a profile with a venous thrombosis identified, sensitivity was 81% and specificity 99%. For pneumothorax, the profile of A prime with a lung point, sensitivity was 88% and a specificity of 100%, essentially being diagnostic for pneumothorax if there is a lung point with an A prime profile. And finally, for pneumonia, this was the most diverse in terms of lung ultrasound profiles. Ultimately, many of the profiles were quite specific but not very sensitive. However, using all three different profiles of A profile plus PLAPS, a B prime, or an A/B/C profile, the sensitivity was 89%. This is just to reiterate the previous slide, but using positive and negative likelihood ratios instead of sensitivity and specificity. And as one can see, for cardiogenic pulmonary edema, again, a B profile has a very strong positive likelihood ratio of almost 20 and a negative likelihood ratio of 0.03. For pulmonary embolism, we can see a positive likelihood ratio of 81 when there is an A profile with a deep vein thrombosis identified and a negative likelihood ratio of 0.2. For pneumothorax, again, the presence of an A prime profile with lung point has almost an infinite positive likelihood ratio and 0.12 for negative likelihood ratio. And for pneumonia, the positive likelihood ratio for any of the profiles listed here was almost 15 and negative likelihood ratio of 0.12. These are examples of A profile with no PLAPS, which would again be most consistent with COPD or asthma, but the differential here is a pulmonary embolism or cause of non-respiratory origin. And so if one were to find this profile, the next step would be to perform a venous scan. And again, just looking in the screens here at the top, we can see that there was A lines bilaterally, good lung sliding, and looking at the PLAPS region here, there's no signs of an effusion or consolidation. In comparison to the A with no PLAPS, the A with PLAPS profile is more consistent with an pneumonia. Again, looking at the screens above, we see in the anterior examination there's pleural sliding, there's A lines bilaterally. However, when we move down into the posterolateral regions and the PLAPS regions, we see a very clear consolidation with an associated effusion. And so this would be most consistent with a pneumonia. Moving into A prime profile, we can see on the right lung here, there's absent sliding compared to the left. And with M mode, we can confirm this, identifying a barcode sign versus a seashore sign. And again, comparing the right versus left in the fifth intercostal space, we see diminished sliding. However, the remainder of the PLAPS examination appears relatively normal. Overall, this is most consistent with a possible pneumothorax, but could also be consistent with other causes of absent lung sliding, including pleurodesis, pneumonia, lung volume loss. And thus, we would need to identify a lung point to be able to diagnose a pneumothorax specifically. And this is an example of lung point, in which case we see within one intercostal space the presence of lung sliding juxtaposed by the absence of lung sliding. And often with respiration, this area of lung sliding will move into the area of absent sliding. And this is pathognomonic for a pneumothorax. Next is the B profile. In this we can see there is lung sliding in both sides of the chest on the left and right, and there are clear B lines diffusely throughout both sides. In this case, the B profile is most consistent with cardiogenic pulmonary edema. However, ARDS and interstitial lung disease are possibilities, but these are more likely represented by the B prime profile, in which there is reduced or absent lung sliding with B lines. In addition, ARDS and interstitial lung disease oftentimes present with an abnormal or irregular pleural line, versus cardiogenic pulmonary edema presents with a normal pleural line. Here's an example of a B prime profile. Notice that in the left, sliding is diminished as compared to the right. Yet we see B lines in both sides of the chest. This pattern is most consistent with interstitial lung disease, or ARDS, and pneumonia is also possible as well. Cardiogenic pulmonary edema is unlikely or less likely when there is an abnormal or irregular pleural line or diminished lung sliding. The AB profile is when we can see B lines, in this example on the right side of the chest, but A lines in the left. In the left, we do actually see some sliding. It's less than the right, but it is still present. And then moving down in the PLAPS regions, we, in this example, see no clear consolidation or effusion. And this AB profile is most consistent, again, with pneumonia, interstitial lung disease, or ARDS. The C profile is the last of the profiles, and in these examples, we can see in the right lung, at the fifth intercostal space, a area of consolidation that appears more tissue-like in echogenicity and has a shred sign present. And this is most consistent with a pneumonia. So to recap, the use of lung ultrasound profiles can be helpful in aiding diagnosis when there is an unclear cause for acute respiratory failure, and this was specifically using the Blue protocol. And again, to develop a lung profile, we need to identify the presence or absence of lung sliding and the interstitial pattern. And when there is a B profile, we think cardiogenic pulmonary edema. There's an A profile, we need to identify whether or not there's a thrombosed vein, and if so, we think pulmonary embolism. In comparison, if there's no thrombosed vein, we then go looking for consolidation or fusions. If there is consolidations in the PLAPS region, we think pneumonia. If there's none, we think more towards COPD or asthma. In comparison to presence of lung sliding, if there is no lung sliding, we look for the presence of A lines, and if there are, we need to try and identify if there is lung point present, and if there is, we would diagnose pneumothorax. If there's no lung point, at this point, other imaging modalities need to be considered to aid with diagnosis. If there is a B prime profile, meaning B lines without lung sliding, we think more towards pneumonia. And all other profiles, the AB mix or a C profile with or without lung sliding, is consistent with pneumonia. And here are the references for this section of the presentation.